Welcome back to the last video of our free training series entitled The Echocardiography Survival Kit. Are you ready? Let's jump right in.
In part 1, we dealt with the basics of echocardiography. In part 2, with left ventricular function. In part 3, with valvular heart disease. So I assume you now have a much better understanding of echocardiography. If you feel the information provided does not yet stick, just go back to the lectures. They're yours. By the way, do you see how powerful e-learning is? Just try to find a speaker at a conference to repeat his lecture for you, maybe even in your own living room.
The fourth and last part of this video tutorial is called Bits and Pieces. It will deal with topics that we have not covered yet. It will be a fairly easy and simple lecture because all you have to do is lay back and watch with your eyes graze to look at the beauty of echocardiographic images. Just as beautiful as this horse is. But before I deal with today's topic, as always, first a short review of what we did last time. I explained the anatomy of the aortic valve and showed you how to image the aortic valve. I did the same for the mitral valve and explained that it is important to look at the aortic valve from more than one view. The parasternal long axis view. Here's an example. The parasternal short axis view. Another example. In this view you can see the three cusps of the aortic valve. The apical 5-chamber view. All you have to do is tilt the transducer from a 4-chamber view into a 5-chamber view. Another example. This view is ideal to quantify aortic stenosis with the help of Doppler. The apical long axis view. Here's an example of the aortic valve. Then I showed you a few examples of aortic stenosis to help you get a feel for reduction in valve opening and calcification in the short axis view. This was an example of severe aortic stenosis. And here an example of mild aortic stenosis. I explained to you the importance of bicuspid valves and that in such valves you can find stenosis without having calcification. Next, I discussed the importance of gradients in quantifying the severe aortic stenosis and what gradients are and which importance Bernoulli has in helping us to quantify the severity and his formula, which is velocity squared times 4. Based on the velocity and the gradients, we can quantify aortic stenosis from no stenosis to very severe stenosis. But I mentioned how important it is to also look at other things. For example, a reduction in left ventricular function, hypertrophy, and enlarged left atria. Then I turned to mitral regurgitation, and I mentioned that there are 3 major causes of mitral regurgitation which you most commonly will find in your population. The first is mitral valve prolapse, the second annular dilatation, and the third is coronary artery disease, specifically inferior myocardial infarction. To suspect mitral regurgitation, look at the valve and always suspect MR if the valve looks strange somehow. Important that morphology and MR severity don't always match. Then I showed you an example of a mitral valve prolapse and displayed that there are many things that you can find in myxomatous mitral valve prolapse or morbus Barlow, all the same thing. These include elongated and thickened cords, the prolapse of the valve, thickening of the valve, and a rocking motion of the posterior mitral valve leaflet. To quantify regurgitation, we need color Doppler, and for the first time I explained what color Doppler is. Red means flow towards the transducer, and blue away from the transducer. The higher the velocity gets, the lighter the colors get, and if velocity exceeds a certain level, we have a mixture of different colors, and depending on which color map you're using, maybe other colors as well, such as yellow. With the help of color Doppler, we can quantify the severity, and I showed you a few examples of how we or I would quantify the severity, ranging from trace to mild to moderate and to severe. I emphasized the importance of the proximal flow convergence zone, and that much of quantification should be based on the size of this flow convergence zone. Mitral regurgitation should be suspected if you have a dilated left ventricle with hyperdynamic function. We call this volume overload. Here's such an example. Leaflet restriction is another potential cause of mitral regurgitation. It can occur, for example, in the setting of coronary artery disease, specifically inferior myocardial infarction. Such a problem is depicted in these images. We have a scar in the inferior posterior region with restriction of the posterior leaflet and severe mitral regurgitation. And finally, I also mentioned that there are other causes for mitral regurgitation as well, which I briefly mentioned, such as endocarditis and rheumatic heart disease.
Okay, so now to the final part of our echo survival kit. Here I put a few different pathologies from different chapters and topics together that you will frequently encounter, and topics that are not so difficult to diagnose.
Echocardiography has a lot to do with pattern recognition. Once you've seen a pathology, you will always remember it, similar to the way that you will always recognize the Eiffel Tower once you've seen it. Similar to the way you will recognize a pathology such as pulmonary hypertension, hypertrophic cardiomyopathy, tricuspid regurgitation, or an acute myocardial infarction. So are you ready? Ready for a countdown? We have 7 cases for you, and at the end, Franz is going to give you a very important message. What is wrong with this patient? What is abnormal in this 4-chamber view? Just compare it with a normal 4-chamber view on the right. It's easy to appreciate that the right ventricle is very large and the left ventricle is rather small. So we have a dilated right ventricle. If you see this in echocardiography, the next question should be why? There are numerous different reasons for a dilated right ventricle, but the most common causes are pulmonary hypertension, a shunt because of an atrial septal defect, and tricuspid regurgitation. Often, these can also be combined, especially pulmonary hypertension and tricuspid regurgitation.
When you learn echocardiography, first focus on the 2D image. You will be able to make the diagnosis, or at least suspect the diagnosis, in most patients. This is also true for pulmonary hypertension. I would say there are 2 major features you should be looking for. The first is the right ventricle is larger than the left, and the second, there is septal flattening. So look for these 2.
Septal flattening is the result of right ventricular pressure overload, which presses the septum towards the left ventricle during systole, or right ventricular volume overload. Septal flattening can be subtle, moderate, or very severe, as you would see in this example here on the right. The left ventricle is severely distorted. 6 more examples to go. What do these 4 images all have in common? Take a few minutes to look at each individual of these image loops. They all have coronary artery disease. What you can see in these patients is that they must have had a myocardial infarct, an occlusion of a coronary vessel, specifically the anterior coronary vessel, because you can see regional wall motion abnormalities in the apex. Compare the contractile function in this part of the myocardium, the distal septum, with the remaining myocardium. Can you see that it is hypokinetic? It does not contract as much as the rest. The same is true for this ventricle, only that the wall motion abnormality, the region, is even larger. Large parts of the septum are involved. This is also true for this ventricle right here, and this patient here as well. In contrast, the other 3 patients had a rather large myocardial infarction with significantly reduced left ventricular function. You now know how to quantify left ventricular function. Coronary hyperperfusion, ischemia, and acute infarcts can cause wall motion abnormalities and eventually scarring. We can define the degree or describe wall motion abnormalities by determining how much the myocardial thickens or moves. If it moves more than normal, we speak of hyperkinesis. If it contracts normally, of normal kinesis, a bit less than normal, hypokinesis. If it does not move at all, akinesis. And if it moves the other directions during systole, we talk of dyskinesia. What exactly should we be looking for to detect wall motion abnormalities? A thin wall, this is such an example. Wall motion abnormalities, as I described them, you can see them here in the inferior part and the entire septum. A distorted left ventricular shape. Just take a look at this ventricle here. It does not look like a bullet anymore. And the myocardium should be fairly echogenic if you are looking for a scar. Do you want to see more examples? To detect regional wall motion abnormalities, you need a lot of examples. Here are a few more. A 2-chamber view. This is the anterior wall. This is the inferior wall. The inferior wall is thin, echogenic, and does not move. This is a scar. 2-chamber view. Normal motion of the anterior wall, but the inferior wall has an echogenic part to it and is hypocontractile. This is a patient with an occluded right coronary artery and an inferior myocardial infarction, where part of the myocardial infarction is probably not transmural because the wall is not thin in all parts. 2-chamber view, small infarct. This is where the regional wall motion abnormality is. Another infarct, but this time we can also see a dilated left ventricle and a distorted left ventricle with an aneurysm. This part bulges out, is thin, and does not move. We would describe this as an inferior aneurysm, which is less common than aneurysms of the apical wall, by the way. An atypical apical long axis view. The wall motion abnormality can be seen here. This is the posterolateral region of the myocardium. Infarcts here are either caused by RCA, right coronary, or circumflex occlusion.
Detecting regional wall motion abnormalities is probably one of the most difficult things in echocardiography. It is especially here where it really pays off if you can produce good images.
5 pathologies left. Compare the images on the left to those on the right. Which ventricle would you rather have? This ventricle or this ventricle? Would you prefer to have this ventricle or this ventricle? Which ones are diseased? Which ones are normal? I'm not trying to make you hungry. I just want to show you the pathology. The patients on the right had left ventricular hypertrophy. You can quantify left ventricular hypertrophy by just measuring the septal thickness in end diastole. On the left we have a thickness of 9 millimeters, on the right 50 millimeters. Before I explain you what the normal values are, I want to again ask the why question. Why do patients have left ventricular hypertrophy? Genetic, sports, hypertension, infiltrative disease such as amyloidosis, aortic stenosis. These are just a few possibilities why patients could have left ventricular hypertrophy. In reality, however, it's very simple. 90% of patients have left ventricular hypertrophy because they have hypertension. Still, always think that there could be other causes as well. And again, look at the patient, measure his blood pressure, and look for other signs of arterial hypertension. But now a short demonstration which will show you how you can tell if a patient has left ventricular hypertrophy.
So this is how you would perform a measurement of the interventricular septum with 2D. In principle, you can use both the apical and the peristernal approach. I will first show you the peristernal approach, where I would recommend the short axis view. You would try to again optimize the image and freeze the image at end diastole, and then simply perform a conventional 2D measurement of the septum. I personally prefer the apical view to measure the interventricular septum. To get good measurements, it's advisable to try to again tilt the transducer in such a way that we have a better angulation of the ultrasound beam with the septum. In other words, that we're more perpendicular. So I'm more lateral now with the transducer position. Then I freeze the image. Then I perform a measurement of the septum, which I would perform in a region of the septum which is located where you would also measure the M mode. So it's between the mitral valve and the papillary muscle. However, I would avoid to measure the maximal thickness if the patient has prominent mid-ventricular septal hypertrophy. So I would then measure somewhere below or above this region.
So the magic number for the cutoff value for left ventricular hypertrophy is 11 millimeters. A number you should not forget, especially if you are a soccer fan. And now to a special form of left ventricular hypertrophy, to a disease called hypertrophic cardiomyopathy. It's a genetic disease and it leads to prominent thickening of the myocardium. Very often, hypertrophy is asymmetric, as in this case. You can see that the septum is very thick, much thicker than the lateral wall here. Another example, another patient, another view, this time the apical long axis view, but the same features. Significant left ventricular hypertrophy, more prominent in the septum than in the remaining part of the left ventricle. But this image also shows another thing which is very common in these patients. We can find obstruction. Obstruction caused by the mitral valve itself. Do you see how the mitral valve occludes the left ventricular outflow tract here? This is the so-called SAM, or systolic anterior motion of the mitral valve. With the help of color Doppler, we can see that there is turbulent flow in this region, which means there is flow acceleration caused by the obstruction. With continuous wave Doppler, we can even quantify the severity of obstruction, similar to the way we do it with aortic stenosis. Look for this feature, because it can be very important, especially in the setting of acute emergencies. Oh yes, one more thing I want to mention. Don't forget, patients with left ventricular hypertrophy often have very small ventricles, and we tend to overestimate left ventricular function in such small ventricles. Don't forget this. Only 4 more pathologies to go.
Oh, by the way, before I forget, you can always interrupt me, play me again, or fast forward me. I won't even notice if you leave the room or if you fall asleep. You can even show me to a friend, but whatever you do, just don't duplicate me and send me off to China.
Now back to the next pathology. Wherever you are watching from, and may it be from China, sooner or later you will be confronted with a pericardial effusion. Here are 2 examples. A long axis view with an echo-free space here and here. This is pericardial effusion. So, look for an echo-free space. And if you detect pericardial effusion, ask the following questions. Where is it? In this case, pericardial effusion is located in the region of the right atrium and probably also here lateral to the right ventricle. Why is it there? Well, very often you will not find a reason. In this case, I know the patient also had an anterior myocardial infarction, and we see pericardial effusions quite frequently in the setting of an acute MI. And finally, answer the question if pericardial effusion is relevant. If the patient has symptoms because of pericardial effusion, in the worst case, tamponade it. But before I talk about tamponade, a few more examples. Small pericardial effusion just located in the inferior region. Bit larger, this pericardial effusion is circumferent. And very large. Note how the heart swings within the fluid-filled sac. We also call this swinging heart. These were some examples of the short axis view, but probably the best view to examine the pericardial effusion is the subcostal view, the subcostal four-chamber view. And here are a few examples. Very small pericardial effusion, a bit larger, even larger. This I would already consider a large pericardial effusion, and this is a very large pericardial effusion. Note that for the definition of pericardial effusion, separation of the epi and the pericardium has to be present during diastole. Very difficult to answer from the echocardiogram. You have to be fairly experienced, but there are some signs that you should be looking for. Compressed and small chambers, abnormal septal motion, and Doppler signs. But I will give you a tip which will make it much easier for you in clinical practice. The most important thing is just simply look at the patient and understand his clinical problem. But even then, things can be very difficult at times. To illustrate that, I would like to tell you a story that happened to me when I was still young.
I remember seeing a patient with acute dyspnea once while I was still in my internship. I was supposed to rule out pericardial effusion. The only problem was the patient had a terrible image quality. And at that time, I was not very good at imaging either. But I did see this echo-free space. And so since the patient was literally in shock, I was kind of convinced that she had tamponade. Well, we were already prepared to put the needle in her. Luckily, a very experienced physician, who was also in call and also my mentor, just came in the room, took the transducer, looked at the inferior vena cava, and saw that it was only a few millimeters, and simply said, "This cannot be tamponade." And he was right. It is highly unlikely that tamponade is present if the inferior vena cava is completely collapsed.
And this is how the inferior vena cava looks if there is tamponade. A patient who had myocardial rupture with intrapericardial hematoma. You can see the hematoma right here. The vena cava is significantly dilated and the diameter does not change at all. Normally, you would get a decrease in the diameter during inspiration. This concludes the topic on pericardial effusion. We're almost done. 3 more to go. Do you recognize the difference between the image on the left and the one on the right? Aside from the fact that the image quality is poor on the right? I'm sure you do, because what we have on the right is a patient with a dilated aorta. The aorta is much wider than, for example, the aortic root. Now to example where the aorta is even wider, where we can even speak of an aortic aneurysm. The aorta is very large here. It measures over 5 centimeters. Again, an example of a patient with a dilated aorta. This time it's seen from an apical long axis view. This view is not as good usually as the peristernal long axis view. So if you want to quantify the size of the aorta, rather use the peristernal long axis view. Where are the upper limits of normal for the ascending aorta? Somewhere in the range of 34 to 40 millimeters, depending on gender and body surface area. In addition to the absolute diameter, don't forget to observe the shape of the aorta. Some compare it to a mushroom, where you have a wider part, which is the aortic root, and then the ascending aorta, which is a bit more narrow. The region between the wider and the more narrow part is the sinotubular junction. In patients who have an aneurysm, very frequently you will not see a sinotubular junction. The aorta just has the shape of a sausage. However, there are more different shapes, or shapes can vary considerably depending on what type of aneurysm is present. In some patients, the aortic root and the sinotubular junction will be of normal width, and the aneurysm will be located more distally. Other patients have the sausage type I just described, while some patients only have dilatation of the aortic root. This is typical for the Marfan patients. Now the second to last pathology. Rheumatic heart disease. I told you that rheumatic heart disease is very common in some parts of the world, and I know that a lot of our users live in these parts of the world. So you better get familiar with this form of valvular heart disease. Rheumatic heart disease usually affects the mitral valve, causing mitral stenosis. And to diagnose mitral stenosis, you just have to look for a very prominent finding, that of mitral valve doming. What is mitral valve doming? Well, it is the same as if the wind blows into a sail, only that in mitral stenosis it is not the wind but the blood which gets caught in the sail of the mitral valves, specifically the anterior leaflet. Back to the echocardiogram. This is anterior leaflet doming. The leaflet takes on a doming position to the left atrium during diastole. For the sake of demonstration, a live 3D echocardiogram of the mitral valve is seen from the left ventricle. Even here you can see doming of the anterior mitral valve leaflet. And once you've diagnosed mitral stenosis, the next big question will be, is it severe or not? Numerous ways of quantifying mitral stenosis have been described, but in reality the most important thing is Doppler. Doppler measures the flow velocity across the mitral valve, and similar to aortic stenosis, if stenosis is severe, you will get higher velocities. All you need to do is look at the spectrum and you will get a rough appreciation for true severity. Look at these two spectras. On the left is a patient with mitral stenosis. On the right, a patient without mitral stenosis. What is the difference? Well, first of all, the velocities are higher. Look at the scales. And second, the velocity never reaches the zero level here, while in patients who do not have mitral stenosis, this will practically almost be the case unless you have patients who have a very high heart rate. And one other thing, look at the slope of the curve. Compare the slope in this patient with mitral stenosis to this patient who does not have mitral stenosis. It is steep here, while it is rather shallow here. By using this slope, one can even calculate the mitral valve opening area. And what about patients with atrial fibrillation? In patients with atrial fibrillation, the second part of the curve is missing. But still, you can look at the steepness of the curve and calculate the mitral valve area. You are almost through the finishing line. One more pathology to go. And this pathology is aortic regurgitation. Aortic regurgitation is fairly common, at least mild aortic regurgitation. And this is such an example. A 5-chamber view where you can see a small jet from the aortic valve into the left ventricle. Another view to study aortic regurgitation is the 3-chamber view or apical long axis view. In this example, aortic regurgitation is at least moderate, maybe even moderate to severe. Note that mitral regurgitation is also present. In addition to the 5-chamber view and the apical long axis view, also study aortic regurgitation with a parasternal long axis view. Even though we're not parallel to the orientation of the jet, we can still depict the jets very nicely because we are close to the aortic valve. We can see trivial aortic regurgitation even in this view, and mild to moderate aortic regurgitation in this view. What are potential and common causes of aortic regurgitation? Well, bicuspid aortic valves, aortic aneurysms, and rheumatic heart disease. You've heard of all of these pathologies during this echo survival course. And with respect to quantifying aortic regurgitation, it is not very much different than mitral regurgitation. It's based on the jet. One looks at the width of the jet, especially compared to the outflow tract, how wide the jet is, where it originates, the so-called vena contracta, and the so-called flow convergence zone, which we talked about also when we talked about mitral regurgitation. Again, I would like to provide you a little reference scale to help you grade aortic regurgitation. Trace, we hardly see any flow at all. Mild, very small little jet, we cannot see a vena contracta. Moderate, we do see a little vena contracta, and the jet is larger, especially when you compare it to the LVOT. And very severe, very big flow convergence zone, broad jet at its origin, and it fills out the entire LVOT. This was the last pathology of this lesson.
So here our short video tutorial ends. Thanks for staying to the end. For some of you, it might have been the first encounter with echocardiography. For others, a short review. But in whatever setting you work and from which corner of the world you are, I hope this tutorial inspired you to dig deeper into echocardiography. Honestly, it is certainly worth it.
Well, that wraps it up. That was the last piece in our free training series entitled the Echocardiography Survival Kit. I hope you enjoyed this learning experience. We created this training series in order to make you better physicians and sonographers, and we really hope you like the way we teach. If you want to give us feedback, go to facebook.com/123sonography and leave a comment or send us an email at office@123sonography.com. We'll read all your messages. Now, for everyone who wants to take this to the next level and jumpstart your careers, we recommend you check out the following products. They will really help you to become a true echo expert. First, our premium membership. The premium membership is an echo reference tool which you can take with you wherever you go. You will have access to unique tools like our Echo Atlas, the ebook, patient demos, and free access to webinars that we conduct every 6 weeks or so. From your own living room, you can watch us present case after case, right out of our lab. You can find the premium membership at 123sonography.com/membership. And next, there's our platinum product, our flagship teaching module on echocardiography, the Masterclass. The Masterclass is an exclusive echo training program. It only takes place several times a year, and the number of available spots is limited. It's a 6-month program with almost 30 hours of video, at the end of which you will know the nuts and bolts of echocardiography. In this program, we will turn you into a true echo expert, so you can examine over 95% of your patients without the help of a more senior colleague. I have already told you about the incredible results some of our students got out of the Masterclass. In the previous videos, our students successfully used the Masterclass in order to pass their exams and become better physicians. In some cases, they could even save their patients' lives because they had attended our program. It's the most effective way to become truly competent in echo. So if you want to join the Masterclass and make us your echo mentors, then go to 123sonography.com/masterclass or click on the link below. And remember, the Masterclass only takes place a couple of times per year, and the spots fill up pretty quickly. We are fanatic about teaching echocardiography. So come and join our community.